Hey everyone and welcome. As pharmacists, we see herpes virus infections every single day, right? From cold sores to shingles. So today, we're diving into a guide made just for us, focusing on how we can truly optimize antiviral therapy for our patients with herpes simplex and varicella zoster virus. Because, let's be honest, our job is so much more than just counting pills and putting a label on a bottle. It's about using what we know to make a real, tangible difference. We're going to focus on the specific interventions and counseling points that have the biggest impact on our patients' health. So here's the game plan. We'll kick things off with a quick clinical refresher, then get right into the drugs themselves. We'll walk through the three big scenarios you'll see all the time: cold sores, genital herpes, and shingles, before we wrap it all up with the key takeaways you can use in your practice tomorrow. All right, so first things first. To give the best advice, we've got to have a solid handle on the fundamentals of herpes simplex virus, or HSV, and varicella zoster virus, VZV. Okay, here's a foundational point that's really important to lock in. Whether your patient is immunocompetent or immunocompromised, the antiviral drugs we reach for are actually the same. Now, this is where we really come in because our clinical judgment is critical for the dosing regimen. Immunocompromised patients often need higher doses or to be on the therapy for longer. So let's get into our toolkit. These nucleoside analogs are really the cornerstone of treatment, and knowing the subtle differences between them is the key to getting the best outcomes for our patients. So when you look at episodic therapy, you can see some real practical wins here that make a huge difference for patient adherence. Yeah, acyclovir is the old classic, the workhorse we all know. But check out famciclovir. That single-day course is incredibly convenient. And valacyclovir with its simpler dosing. I mean, for our patients, these differences can be absolute game changers. This is a huge point for reassuring our patients. You can confidently tell them that these oral antivirals are exceptionally well tolerated. In fact, in most studies, their side effect profile is basically no different from a sugar pill. So while, yeah, a mild headache or some nausea is possible, you can let them know that significant side effects are really rare. That can go a long way in easing their anxiety. All right, let's talk about something we see at the counter all the time: orolabial herpes, or as everyone calls them, cold sores. This is one of those areas where our proactive counseling can make a massive difference. So what are we actually trying to achieve here? Well, our goal is super patient-focused. We can't cure the latent virus, we know that, so we focus on what we can do. Manage the active infection, make the symptoms less severe, and help cut down how often they get these outbreaks. Now this right here, this is probably the single most effective strategy we can promote. It's called patient-initiated therapy. We need to counsel our patients to get a prescription in advance. That way, the moment they feel that telltale tingle, they can start treatment right away. This one simple move can shorten the episode by about a day, and more importantly, it puts them back in control. You know how often patients come in asking for those over-the-counter creams, right? Well, this is where we can gently guide them. The evidence is crystal clear. Oral therapy is just way better. The topicals aren't just less effective. They have to be applied constantly and even carry a risk of spreading the virus. So this is a definite evidence-based recommendation we can and should make with confidence. Okay, we're gonna shift gears now to a topic that's a bit more sensitive, but honestly so common: anogenital HSV. Our role here as an accessible, non-judgmental healthcare provider is absolutely vital. We're providing both clinical guidance and, just as importantly, support. When we're talking about managing this, we're really wearing two hats. On one hand, we're focused on the individual patient, improving their symptoms, reducing how often they have outbreaks. But on the other hand, we have this crucial public health role to counsel them on how to prevent transmission. The two really go hand in hand. This is an absolutely critical counseling point. I can't stress this enough. Suppressive therapy is fantastic, and it significantly reduces viral shedding. But, and this is a big but, it does not get rid of it completely. Patients have to understand that to best protect their partners, using condoms is still necessary even when they're on their daily antiviral medication. So the decision to start suppressive therapy? That should be a conversation, a joint decision based on the patient's quality of life, not just some rigid number of outbreaks. It's also really important to note that for many people, the frequency of outbreaks goes down over time. That's why pausing therapy every so often, maybe every 3 to 6 months, is a great strategy to see if it's even still needed. All right, let's move on and talk about VZV reactivation, or as we all know it, shingles.
This is another area where our prompt intervention, from treatment advice to vaccination counseling, is just so important.
With shingles, the clock is absolutely ticking. Starting an oral antiviral within 72 hours, 3 days of that rash showing up is critical. It can reduce the severity of the pain and shorten how long the virus is shedding, which just gets our patients on the road to recovery that much faster.
Now, when we talk about shingles, prevention is everything. And look at this number, 97%. The effectiveness of the recombined zoster vaccine is just incredible. Shingrix has fundamentally changed the game in our ability to prevent not just shingles, but its worst complication, post-herpetic neuralgia.
This slide really breaks it all down for you, giving you the key talking points for your counseling sessions. Probably the most important distinction here is that Shingrix is a non-live vaccine. That means it's an option for a much wider range of patients, including many who are immunocompromised. You combine that with its vastly superior efficacy, it's really the clear choice. And hey, let's not forget the simple stuff. This non-pharmacologic advice is so powerful. These are practical, easy things patients can do to prevent nasty secondary bacterial infections, stop transmission to people who aren't immune, like grandkids who haven't had chickenpox, and just generally feel more comfortable. Okay, that was a lot of information, I know. So let's boil it all down into the most essential, high-impact counseling points that you can start using right away. So let's bring it all home. Number 1, timing is everything. Start that therapy at the very first sign. 2, empower your patients. Push for those advanced prescriptions. 3, always counsel on prevention. Safe sex for HSV, vaccination for VZV. And finally, number 4, set realistic expectations. These drugs are great for managing symptoms, but they are not a cure. This quote right here really sums it all up. This is our call to action. It's about leading a shift from being reactive to being proactive. Empowering our patients to start their own therapy isn't just a clinical tactic, it's how we show our value and directly improve their quality of life. And really, this proactive approach is just the start, which leaves us with a pretty big question. As the most accessible healthcare providers out there, what's the next barrier we can help our patients break down? Our role in managing these chronic conditions is only going to get bigger. Thanks so much for watching.